Welcome to today's presentation on cardiac rhythm monitoring. Your expertise as healthcare providers is critical in managing patients with cardiac conditions. Cardiac rhythm monitoring requires your specific skills and knowledge. It involves continuously observing patients' heart rhythms to allow timely interventions for potentially life-threatening arrhythmias. In this session, we will discuss CRM's specific criteria, including when to start and stop monitoring based on patient conditions. Cardiac rhythm monitoring is a crucial clinical tool used in general ward settings, especially for patients who do not require intensive monitoring in specialized units such as the coronary care unit or intensive care unit. This service, managed by skilled coronary care unit nursing staff, focuses exclusively on rhythm monitoring without assessing hemodynamic status. Effective use of CRM, by understanding the specific indications for monitoring and the criteria for safely discontinuing it, can significantly enhance patient safety and reduce the risk of adverse cardiac events. By adhering to these protocols, you ensure appropriate utilization and make a real difference in patient care. It is crucial to continuously monitor patients who have experienced cardiac arrest or significant arrhythmias such as ventricular tachycardia, ventricular fibrillation, or supraventricular tachycardia. This continuous monitoring allows for timely interventions and ensures patient safety. Monitoring is also necessary for narrow complex tachyarrhythmias, causing hemodynamic instability, symptomatic bradyarrhythmias, and advanced atrioventricular block. In addition, patients with new or unstable atrial fibrillation or flutter receiving intravenous antiarrhythmic drugs should be monitored due to the potential for these medications to cause further arrhythmias. Monitoring should continue for at least 24 hours or until a reversible cause is identified and treated, cardiac symptoms are stabilized, or a cardiac device is successfully implanted and tested. Monitoring should be maintained for atrial fibrillation or flutter until the patient is stable, asymptomatic, and their heart rate is controlled or has reverted to sinus rhythm. Patients with significant arrhythmias should always be transferred with an AED due to the high risk of sudden cardiac arrest. Acute coronary syndrome encompasses conditions that range from unstable angina to myocardial infarction. Continuous monitoring is necessary for intermediate to high-risk ACS, including non-ST elevation and ST elevation MI, as it helps in early detection of irregular heartbeats and ischemic changes, guiding further treatment. Patients with multiple comorbidities are at increased risk of adverse cardiac events and benefit from prolonged monitoring. For ACS patients managed medically, monitoring is recommended for 12 to 24 hours or until myocardial infarction is ruled out. If further cardiac investigations, such as transthoracic echocardiography or angiography, are planned, monitoring should continue until the cardiology team has been consulted and the results have been reviewed. For ST elevation MI patients, monitoring should extend until discharge. Given the irregular heartbeat risks associated with ACS, all transfers should be conducted with AED support to manage any potential life-threatening arrhythmias. Patients with significant cardiac conditions such as myocarditis, infective endocarditis, chest trauma, and acute decompensated heart failure may require cardiac rhythm monitoring due to the risk of arrhythmias caused by inflammation, infection, or structural damage to the heart. Monitoring should continue for 12 to 24 hours or until symptoms resolve, the patient achieves clinical stability, or at the cardiologist's discretion. For acute decompensated heart failure and cardiomyopathies, monitoring should be maintained until precipitating factors such as volume overload or ischemia are successfully managed. It's important to note that patients with these conditions are susceptible to arrhythmic events during transfers and may require AED support to ensure safety. Patients undergoing cardiac investigations or interventions, such as those awaiting for ICD or pacemaker implantation, are at high risk of arrhythmias. Monitoring is essential to promptly identify arrhythmias, especially in those who received ICD shocks or undergoing pre-operative procedures such as CABG or electrophysiological studies. After angiography or PCI, monitoring is crucial to detect potential procedural complications, including arrhythmias. Monitoring should continue for patients awaiting device implantation until the device is implanted and tested by the cardiac physiologists. Post-PCI monitoring may vary. STEMI patients require monitoring until discharge, while elective procedures may only need 2 hours of observation in the post-procedure area. Transfers of these patients should always include AED support, given the heightened risk of arrhythmias and the need for immediate defibrillation in emergencies. It is crucial to monitor the QTC interval for patients taking antiarrhythmic drugs such as IV amiodarone or flecainide, as these medications can prolong the QT interval and increase the risk of life-threatening arrhythmias. Rhythm monitoring is also necessary during infusions of other drugs that can affect cardiac rhythm, or in cases of drug overdose where toxicity may impact the QTC interval. Monitoring should continue until the QTC interval returns to normal, the infusion is completed, and the patient stable with no evidence of arrhythmias. Due to the potential for prolonged QTC to cause arrhythmias, immediate access to an AED during transfer is vital. Syncope is often linked to heart rhythm issues, such as fast or slow heartbeats. Finding the underlying cardiac causes may require cardiac rhythm monitoring. Continuous monitoring gives essential information about the heart rhythm during these episodes, which can help with diagnosis and treatment. Monitoring can be stopped once no heart rhythm issues are found, the patient stays stable, and the cause of syncope is identified and managed according to relevant criteria. When transferring the patient, having AED support is important in case of unexpected heart events during transport. Electrolyte imbalances such as low or high potassium, magnesium, or calcium can disrupt the normal functioning of the heart and lead to serious irregular heartbeats, including high-grade AV block. Monitoring allows for early detection of irregular heartbeats, enabling prompt correction of electrolyte levels and stabilization of the heart rhythm. Monitoring can be discontinued once electrolyte levels return to normal and no irregular heartbeats are observed. Due to the high risk of irregular heartbeats with severe electrolyte disturbances, it is mandatory to have AED support during patient transfers. Submassive pulmonary embolism with evidence of right heart strain or elevated cardiac biomarkers indicates significant cardiac stress. This can predispose patients to arrhythmias. Continuous rhythm monitoring helps to monitor for rhythm changes that may require immediate intervention. Monitoring should continue for up to 24 hours or until arrhythmias are ruled out and the patient's hemodynamic status is stable. Transfers should include AED support to manage any sudden arrhythmic complications effectively. Ischemic stroke, transient ischemic attack or TIA, or cryptogenic stroke may be caused by underlying cardiac arrhythmias such as atrial fibrillation, which can lead to embolic events. Continuous rhythm monitoring can help detect these arrhythmias early, influencing the management of anticoagulation and stroke prevention strategies. Monitoring should be maintained for 24 to 48 hours after the event to detect AF or other arrhythmias. If atrial fibrillation is detected within 24 hours, monitoring should be stopped and appropriate management should be initiated. AED support is not typically required unless the patient has a significant cardiac history or ongoing arrhythmic risk. Cardiac rhythm monitoring is a crucial tool for managing patients with heart conditions. Adhering to the defined inclusion and completion criteria ensures that telemetry is used appropriately, improving patient care and optimizing resource use. Understanding when to monitor and safely discontinue can help clinicians improve patient outcomes and reduce unnecessary telemetry use.